International iDOS Conference 2021. I would request the chairpersons to please switch on the camera and unmute themselves, starting with Dr. Mahipal Sajdev. We've got Dr. A.K. Grover, Dr. S. Bharti, Dr. J.S. Tityal, Dr. Sanjay Chaudhary, Dr. Radhika Tandon, Dr. Namrata Sharma, and Dr. Vipul Nayar. I request the chairpersons to please invite our first speaker, Dr. Steve.
So there are a lot of chairpersons.
We'll start with Dr. Tityal to make the first invitation, please.
And yes, Dr. Tityal may please introduce the first speaker.
Yeah, thank you, DOS, for a kind invitation to us also. And very excited to be part of this international people. Dr. Steve Arsenault, we all know him. He's been with us for an entire year. And this year also is going to go like this only, the way things are going. And his work, we all know. He's been a pioneer in every field of not only cataract, in entire ophthalmology. And we'll be delighted to hear him and learn many things from him. Dr. Steve Arsenault, please.
Dr. Tityal, thank you very much. Let me just share my screen. You've disabled my screen sharing.
Audio visual, please, can you enable the screen of Dr. Arsenault?
Yes, already allowed, ma'am.
Okay, now I got it. All right, thank you very much. Okay, so thank you, Dr. Tityal. I'd like to speak to you about a bit of a different topic. Can you see my screen now? Hopefully.
Yeah, nice and clear.
Very clear. And
so I'm going to talk to you about the role of rheology in artificial tear solutions. This may seem to you all to be a strange topic. First, I'd like to thank you very much for inviting me to take part in your meeting. It's a great pleasure to do so. I love meetings in India, and I have lots of friends there, and I really enjoyed taking part. I also want to thank my co-authors. This is a rather unusual presentation. We have 3 authors, and we published 2 papers together in the Journal of Cataract and Refractive Surgery. They're just being published now. Ilan Hoffman is a polymer chemist, and Hemi Nai is a rheologist. And when you hear the paper, you'll understand why I had to work with 2 people in those fields, because I don't know much about those things, although I know as much as most ophthalmologists. So to get on with the topic, dry eye disease has been defined by the DEWS 1 and DEWS 2 workshops, and it's written up there. I'm not going to read it to you. But basically, there are 2 broad categories of dry eye disease, either aqueous deficient or evaporative. And the thing that's interesting with dry eye disease is we actually know extremely little about this, despite the fact that there are endless numbers of artificial tears sold all over the world. And in all types of dry eye disease, we almost always begin treatment with artificial tears. So we should really understand artificial tears more. I've worked a lot on OVDs, but not that much on artificial tears. And we thought we would work on this. And this project took us about 5 years. So there are numerous over-the-counter preparations of artificial tears, at least in Canada, and the US governments do not cover these things and people buy them themselves. It's interesting we look at our drugs in different ways. And if you look at artificial tears, they're really all palliative in that they relieve symptoms and provide comfort, but they don't resolve the problem. That's why they sell so well, because you need more 10 minutes later. And there are multiple confusing ingredients of artificial tears, which have their own nomenclature. We have things called demulcents, which basically are things that soothe your tears. They relieve irritation with cellulose derivatives, polyols, and chemicals like that. We have things called emollients, which basically are lipids or fats and oils, which would decrease the evaporation layer, much that the oils in our tears do. And we have many other things that are artificial tears. If you read the bottles of the tears you get, they're quite confusing. We have rheological additives like hyaluronan, viscosity enhancers like hydroxypropyl guar, thickeners like sodium carboxyl methylcellulose, gelling agents, carbamers, and numerous chemical contents, osmoprotectors, bioprotectors, anti-inflammatories, free radical scavengers, buffers, electrolytes, all kinds of stuff in these tears, and most of us don't really understand it. So I'm going to talk about rheology. That's my favorite subject. And the favorite rheological agent now in artificial tears is hyaluronic acid or hyaluronan. It can be viscoelastic or elastoviscous. It's named by which of the properties is most predominant. So viscoelastic for artificial tears, for ophthalmic viscosurgical devices, but elastoviscous really for artificial tears. And it has a high water retention capacity. Now, hyaluronan was first found to be effective as an artificial tear, and the first one used was Helon in the 1970s. And then a number of us, with Andre Balazs, began to look at making specific artificial tears for dry eyes. And the first one was made by a biomatrix called Hylashield, and I was the first in the world to use it. I made it with Andre Balazs and Ilan Hoffman, a co-author of the paper. And I treated this patient that had severe Sjogren's syndrome so bad that he could not operate the bus, which was his occupation. And when we gave him Hylashield, he was unbelievably better. He went from not being able to work for more than an hour to being able to work his full day and basically function normally, taking these drops. Unfortunately, Andre Balazs' company, Biomatrix, which made this, was sold to Genzyme in 2000, and then Hylashield was no longer available to us. But Ilan Hoffman and I, two of the three authors, believed that rheologically designed tears should benefit patients the way that Hylashield benefited our patient and other patients we tried that weren't as outstanding. And so we began to work on this and try to figure out how we could make artificial tears. So let me tell you a bit about hyaluronan. Well, as you all know, we know it best for OVDs. And the study of rheological properties in OVDs has really told us a lot of information, but it's information about surgery and not really about artificial tears. And the part in the box is one of the most important parts of this talk, that surgeons, unlike clinicians who treat dry eye disease, are interested not so much in how OVDs behave when they flow, but their behavior at rest just up to the point when they're about to flow. Because once they start to flow, they cease to provide their function. And the role in artificial tears is opposite. We actually care how they behave when they flow, and their rheological properties change at different speeds of flow because the speed of blinking varies dramatically from when it's still to going very fast. So there are basically four patterns of rheological behavior of all fluids, and you see them here. They're Newtonians, which don't change with shear rate. Their viscosity is constant across different shear rates. And then we have these three other kinds, the plastics, which become solid at zero shear, but of course we can't use that in ophthalmology. So we have pseudoplastics, which remain fluid, but with very high viscosity at low shear, but become very non-viscous and fluid at high shear. And then we have some things that are dilatant, like egg whites. When you beat them, they're the opposite. But if you look at OVDs, you can see that all of them are pseudoplastic. And you have this part of a curve, which really is only a small part of the curve of all of rheology. And I want you to remember this shape to show you later what happens when we look at artificial tears, when we're interested in how they flow, not just how they behave until they flow. So let's talk about tears a bit. Well, tears are really thin. Their estimated thickness is from 3 to 46 microns, and there are all kinds of mathematical models of the tear cycle, and a lot of them account even for gravity, whether you're standing up or lying down, evaporation, if it's windy or not, and all kinds of things. But the duration of a single blink is really, really fast, between 100 and 400 milliseconds. And artificial tears, as you all know when your patients complain to you, are much thicker than human tears. And when the patients put them in, a lot of them complain they're too thick and too viscous. So we tried to measure, and many people have tried to measure, tear thickness after you place artificial tears in. And one of the most good studies was done with reflex liquigel. And we found out that when you put the artificial tears in the eye, that the tear thickness went from 3.2 to 35.6 microns, but by 5 minutes, it was insignificantly different from baseline. And patients often tell us that tears don't last very long, and we believe them, but we have nothing better. But when this study was done using hyaluronic acid teardrops, we found out that in the same experiment type thing, that the statistically higher thickness of the tears remained for 30 minutes and not 5 minutes. So we have good evidence that rheologically based artificial tears are probably better and last longer. So now, if you look at rheology, you'll recall here, this middle part of the curve is the part that you saw when we looked at OVDs. And the number over here is 100 to 1,000 times lower than what we have in OVDs, because you can't put Helon 5 in someone's eye as artificial tears because they just can't see. So we make these solutions that are not nearly as viscous, and they're much more elastic. And you see here you have two horizontal levels. You have the level here called the high Newtonian plateau where the viscosity doesn't change. And that's how it is when it sits in the meniscus when the patient is not blinking. And then when they blink, you get faster and faster blinking and the tears thin out. And then here you have a high shear viscosity plateau. And that is when the blink is at maximum speed and hopefully the tears thin over the central cornea to allow the patient to see well. And this is contrasted to what happens with a Newtonian solution where it doesn't change at all. So we expect that these kinds of tears should be better than these. And we did a study to see if that's actually true. So we looked at a whole bunch of artificial tears we got from Canada and the UK because we could buy them easily, and we compared them. And by measuring them all in rheological experiments, we found out that we could divide them into 3 different groups. We had group A, which had significant shear thinning, means they were pseudoplastic, but had also the high and low Newtonian plateaus. And you see them listed here in the curves, which show you they actually behave reasonably well, sort of like OVDs, but at a much lower level. And then we had some that had moderate shear thinning, which really is very little shear thinning, but just enough we could measure something. And then some in group C that had no shear thinning whatsoever. And so the question is, which ones are better for whom? And if you look at the companies here and you look at your patients, you'll see that some patients like these, group A, some patients like group B, and some patients like group C. And that's one of the problems, in that we don't really understand very well in exactly what's wrong with each patient's tears to know which to replace them with. But we can study them to try to figure out how we can make better ones. So one thing that's interesting, if we measure these OVDs, we measure something called normal stress, we find out that normal stress means when you take, let's say, Helon and inject it through a syringe, when it comes out of the cannula, it spreads out into a ball. And that's because when you force a polymeric solution that's viscoelastic down through a cannula, the molecules align themselves in the line of the shearing force, but they exert force in a perpendicular direction called the normal stress, wanting to return naturally to their spherical shape. And you can measure this. And in group A, you can see as we increase the shear rate, every one of these showed that they were elastic and they had a significant normal stress. Group B had much lower normal stress, which shows they are a lot less elastic. And group C we don't show because they weren't elastic at all. They showed nothing. So what does that tell us all? Well, it tells us that we can divide our artificial tears into 3 different groups based upon how they behave rheologically. And hopefully that tells us not what's better, but that we can design ones that are better. So human tears exhibit multi-layered shear thinning. And so we would expect that artificial tears that exhibit similar shear thinning should be more comfortable and last longer. And in our bus driver who got us going on this, it was absolutely the case. And he was much, much better with a viscous elastic, or actually elastoviscous artificial tear. Over-the-counter tears that we were able to buy vary considerably in their rheological properties, and we can divide them into 3 groups based upon how much shear thinning and how much normal force or elasticity they demonstrate. And hyaluronic acid tears seem to yield the best shear thinning of all the molecules that we could find or have been tested so far. And that probably explains why numerous companies are all adding hyaluronic acid into their artificial tears. But it's important to remember that artificial tears can be manipulated. So generic equivalence does not mean equivalence. So both OVDs and artificial tears, when you use them, when you publish an article, you must state which company's tear or OVD you're talking about, not give a generic name, because they're not at all equivalent. So let's say all 1% hyaluronic acid OVDs are very different. And all of the tears that have artificial tears with hyaluronic acid are very different from each other. So you must state what they are. And we think this kind of work will give us some direction and an experimental basis to design more effective preparations and to understand how they work. There are significant limitations in this kind of a study. One, we wrote relatively poor, but I think it's extremely poor understanding of human tear rheology compared to, for example, OVDs. And the second is, this is the first study we're aware of globally to try to look at the rheology of artificial tears. And so we can't really compare the data we derive to what patients experience. So we all know that patients, some like one kind of tears, some another. And we think a lot of work has to be done to try to sort out what makes a patient prefer one kind of tears to the other, and to let us then design something better for each patient. And we hope that we will get many patients like our bus driver who will be responsive to tears that we design, hoping that they will be better. So that's it. Thank you very much.
Short question for you, sir.
Yes.
When we say that hyaluronic acids are working best, and you say the high shear element is supposed to be the most useful, is it true that we should use only hyaluronic acid as a lubricant, or it should be in addition to some more formulations to make a better option?
We don't know. As I said, what we did in the study is we analyzed the tears, 20 kinds of artificial tears. We could divide them into 3 groups. We found that our bus driver had a phenomenal response to hyaluronic acid-based tears, which were not formulated like OVDs. They were formulated to be elastoviscous at a low concentration of 0.15%. But that doesn't tell us that every single patient is like that. Some patients prefer watery drops. They made TheraTears because some patients had aqueous deficiency and really just needed water. And I think we have to understand our artificial tears more and our patients more before we can say what we should give a specific patient. And what I do is I experiment. I give the patient 3 or 4 kinds and I say, why don't you try these and let me know which is better. A lot of patients like hyaluronic acid-based tears, and we find, at least in Canada, where we have cold weather with low humidity in winter, that patients prefer mostly the artificial tears that have hyaluronic acid, but I can't say that'll be the same everywhere for all kinds of patients. It's going to vary.
And what is the frequency of drops you use for hyaluronic acid? Frequency of drops used. What is the frequency of drops you use for this?
That's a very tough question because it needs a long answer. I live in Canada. In winter, the humidity in Toronto is 20% when everything is frozen. In summer, it's 85% because we get the humid air blowing north off the Gulf, Mexico. So the frequency of the patients using tears can be 7 or 8 times a day in winter, but maybe not at all, or once a day or twice in summer. So it just, and then if you go to different parts of Canada, like Alberta, which is very dry, the patients may actually want more drops in summer than winter. So it depends on the environment that you're in. And that's why I think this is a field where we need a lot more study before we understand it. And a lot of the things that we see marketed are really extremely simplistic. And I think as we understand the field more, we'll be able to do a lot better for our patients.
Right.
In my experience, because I do a lot of refractive surgery, especially laser vision correction, Lasik, and over a period of with the trial and error method, I have also come to this, experience that hyaluronic acid-based lubricants are better as compared to others like even Refresh Liquid Gel, the Hyalo Lasop or Hyalo Commode, which are available, and other hyaluronic acid-based products give better and better feeling and long-term, shorter number of times you may use it for 4 times in a day, and that patient gets control of dryness, post-LASIK dryness. So that's what my experience is.
I agree. I also do a lot of refractive surgery, and I give patients hyaluronic acid tears after refractive surgery. But that's only one specific example of a disorder that patients have. And those patients often need the drops for 3 or 4 months, and then they're better once their corneal surface reinnervates normally. But not all of our patients are refractive surgery patients, although that's one indication where the hyaluronic acid tears, which last longer in the eye, do better.
Same experience,
Yeah. So in the absence of any question on this, sir, would you continue with your second talk, intracameral pupil dilation?
No, Dr. Chaudhary.
So we are moving on to ethical considerations?
Yes.
Yes.
Okay. So may I invite Dr. Christopher Liu for ethical considerations of Isbcs, please?
to unmute yourself. Dr. Christopher, please unmute yourself.
Good evening, everybody. I have been asked to talk about ethical considerations of immediately sequential bilateral cataract surgery, and I'm really pleased to be sharing the podium with Steve Ashenoff and Richard Packard, who are both advocates of Isbcs. I have no financial interest, but for over 20 years, I have been advocating safe delivery of cataract surgery, including the following two modes, Isbcs and cataract surgery by appointment. In terms of medical ethics, there are four established pillars, which are autonomy, beneficence, non-maleficence, and justice or social justice. In terms of autonomy, it is a respect for the patient's right to self-determination. And that really includes it's very important to include informed consent and also to respect the autonomy of surgeons as well, for those who do not wish to offer Isbcs. We will go into that a little further. Beneficence simply means the duty to do good. And the next item, the duty not to do bad. And social justice, to treat all people equally and equitably, and also to conserve resources, so the same amount of resource will go around further and go to next generations as well, so we don't consume everything and leave nothing for future generations. So on the 8th of June, it was 2018, so there's a typo there, that I assembled a group of 30 people, of surgeons for and against Isbcs, patients who've had both modes of delivery, nurses, some of whom were also patients, 2 lawyers, 1 optometrist, 3 ethicists, 3 religious leaders, 1 health economist, and all chaired by Mr. George Mack, you can see here. And we debated for 3.5 hours to answer a number of questions. And those of you who want to spend 3.5 hours watching this, it's all on my channel on YouTube, but it is also on a publication, which I shall tell you about later. Of course, when we are giving patients information on the advantages and disadvantages of Isbcs, here we are with a list of the advantages. Firstly, so there is only 1 referral and 1 preoperative consultation, which is often combined with assessments with biometry and nursing assessment. 1 visit for the procedure itself, no period of binocular imbalance, 1 visit to the optometrist for a sight test, and just one pair of new glasses, rather than change 1 lens and then update the second one when second eye surgery has been done. Health economics is important, not necessarily to individual patients, but for society and globally, it is very important in that it is much more efficient to operate on the 2 eyes at the same sitting. And think about the reduced travel for patients and their carers, time off for patients and carers. And sometimes the relatives are working relatives, so they have to take a day off to accompany the patient. And think of all the reduced carbon footprint as well, when everything can be halved. In the COVID era, where we're operating green streams, then the number of COVID tests required is also reduced. And with green streams, we are asking patients to self-isolate for a fortnight before presenting for their COVID test 2 days before surgery. And that means the 2 weeks of self-isolation and the extra COVID test for second eye can also be avoided. And that's why in the pandemic, Isbcs has become much more popular where it is safe. So there must be some disadvantages. And of course there are, and you are taking, or the patient is taking a risk with both eyes at the same sitting. However, it is not actually simultaneous as such. It is only on the successful completion of the first eye that we operate on the second eye. There will be double discomfort during surgery and in the postoperative recovery. And there are some patients who may not be able to manage putting postoperative drops in both eyes, both freshly operated and unoperated or recovered eye, to use to put drops in the other eye. And of course, there will be potential financial loss to surgeon and institution. And I'm open to talk about this because money is important and everybody has to make a living. So who can offer ISBCS? And obviously, the surgeon has to have a good track record and a good understanding of ISBCS. And the team has to have a good track record and cohesion as well. So it should be an established team rather than just a few people haphazardly put together. And of course, the hospital has to have a good track record, in particular with infection rates. In terms of patients who can have ISBCS, obviously they need to have a bilaterally visually symptomatic cataracts. And at least for the novice bilateral surgeon, the eyes should be low-risk cataract eyes and low-risk patients. And the operations must not be expected to be prolonged because that is a risk factor for endophthalmitis. If there is a need for general anesthesia, especially if the anesthetic is deemed to be high risk, then that may sway towards operating on the two eyes at the same sitting so as to avoid a second high-risk GA. So this three-step safety protocol is now well established and well accepted. Firstly, case selection. So at least for the novice surgeon to stick to low-risk cases. The option not to proceed with the second eye if the first operation has not gone very well. And treating the two eyes as independent operations. So with re-scrubbing, regowning, regloving between the two operations, and using devices, solutions, medicines, and instruments which enter the eye from different manufacturers, or they must bear different batch numbers. And phaco probes in particular should have gone through different sterilization cycles, preferably with one phaco handpiece for one of the two eyes held back from the previous week. So it's already tried and tested on other patients. So excluding high-risk eyes. So these are eyes with a high risk of infection and risk of corneal decompensation, for example, Fuchs's dystrophy, any lenticular abnormalities, and eyes with risk of glaucoma, retinal detachment, either family history or personal history or history in the contralateral eye, risk of biometry error. So in particular, your very long and short eyes, but really nowadays with optical coherence interferometry, biometry error and good formally, biometry error is very much a thing of the past. And where there is risk of intraocular inflammation as well, then stick to unilateral surgery. Just some examples of non-routine cases, very dense cataracts and stuck down pupil, pseudoexfoliation, and hypermature cataract. So the option not to proceed with the second eye is a very important concept in that the risk of endophthalmitis is increased when there is vitreous loss, where the operation is lengthy, and the risk of cystoid macular edema and retinal detachment is increased by vitreous loss. So if there has been a complication or it hasn't gone well, then we do not proceed. And therefore, it is immediately sequential bilateral cataract surgery and not bilateral simultaneous cataract surgery because the two eyes are not done simultaneously. Just to quickly go through my protocol, the majority of cases are done under local anesthesia, and usually I would operate on the eye with a denser cataract, except if there is so much asymmetry that the denser cataract is so dense that it decreases the chance of a successful operation, in which case I would do the less dense cataract first. So this would be for the first eye, the topical and intracameral anesthesia with a long, clear temporal corneal incision and a low threshold to suture the wound as necessary. And then there will be Gelnet gauze, iPad, and the Catella shield. Then the second eye will be a scleral tunnel for added security and also a subtenon's anesthesia to allow for the second eye syndrome. And then that eye has a Gelnet gauze and iPad and the Catella shield. And for the first eye, it will be unpadded and just replaced with the Catella shield so they can go home seeing with their first eye. So I would ask them to wear a shield day and night for the first week for physical protection. And there would be no wear of face mask for the first week for fear of misdirected breath from oral pharynx. Now, let us summarize the ethical considerations having looked at the process. So autonomy, patient choice. The patient should be given a choice when they are suitable, and they should be fully informed of the advantages and disadvantages. So equally, the surgeon should have a choice of not to do ISBCS, but they are obliged to discuss ISBCS and refer to a colleague who offers ISBCS. Obviously, we want to reduce risks to a minimum with very good practice and therefore at the same time not doing harm. In terms of social justice, there is no doubt that there is reduced healthcare costs. So the same money can do more good to more people, and this is not necessarily restricted to ophthalmology. So within ophthalmology, it could be that some money can be diverted to oncology or AMD or pediatric ophthalmology, and outside ophthalmology to any other healthcare costs. And we've already discussed carbon footprint. And for those of you who are interested to read the article, it's in Journal of Medical Ethics, and it's very easily readable. So other purported issues before I close, that people worry about producing two Qs or two lines in American, that yes, there will be an initial hump, but the waiting time will ultimately decrease because whilst we operate on fewer patients per operating list, we're actually operating on more eyes, and they will not need to return for second eye cataract surgery. So also some of my colleagues are worried that, well, if you take away all the routine cases, then who will the residents and trainees operate on? Well, actually, they can operate on the second eye in ISBCS. And if they're competent, they can also operate on both eyes, one after the other. There are extra preparations for theatre nurses in that everything needs to come with different batch numbers or manufacturers. But there is already a move to have pre-packed left eye packs and right eye packs that can be pulled off the shelf quite easily. There are some uncertainties that we cannot answer at this point. We do not know the true risk of phthalmitis, although we do know it is exceedingly low. There is this concept of conditional probability, so that, let's say, if the risk of blindness in unilateral cataract surgery is 1 in 1,000, and then the risk of bilateral blindness is higher than 1 in 1 million, because if something does go wrong in the first eye, then because the second eye belongs to the same patient and bears all the same risk factors, even if some of them are known, then the risk of the same thing happening in the second eye will be higher. So I generally quote conservatively that the risk of blindness in both eyes will be 1 in 200,000, although the literature supports a much lower figure. In terms of cystoid macular edema, we have to recognize that not all cases of cystoid macular edema will resolve. So that is actually, I worry about that more than I worry about bilateral endophthalmitis. So here's a plug for my new book, if you're interested. And I thank you for your attention, and I thank the organizers for inviting and including me.
Thank you for that wonderful presentation, sir. I have one question for you, which is that if I simultaneously schedule both the eyes of one patient, and for some reason there is something which happens in the right eye because of which I don't want to do the left eye, then imagine the stress the patient and the relatives will go through. Doc, what went wrong? What was the problem? Why couldn't you do it? And that could be
Yes, indeed. And in fact, then people worry about having opened the second sets, carefully planned with different manufacturers and batch numbers, that all that is lost. But the reality is that we do not get complications very often. And I think in terms of the stress level, it's a matter of mindset. And I think it's really important that we go out and educate and inform all the patients and all our colleagues so that we don't have this innate fear. That is because, you know, from when we first enter ophthalmology, that we're taught that operating on both eyes at the same time is wrong, it's unethical, it's immoral. But that is going back to very, very old days when cataract surgery is a lot riskier. If you look at lid surgery, refractive surgery, squint surgery, detachment surgery, they're always done bilaterally. So I think if we adjust our mindset, then we will be less frightened. We just need to be very safe. And if we're less frightened, then we will frighten less our patients as well. Because, you know, if we're not sure and we're frightened, the same fear will actually pervade the whole room, and the whole theater will be so frightened. I remember 25 years ago when I first introduced topical anesthesia to my hospital, everybody thought I was torturing the patients. And even the nursing sister, some of the patients died like a few months later. And then the nursing sister was so sure that I killed them because I tortured them with topical anesthesia. So it is a matter of mindset, I think. Anyway, I'm probably talking rubbish, so I'll keep quiet now.
No, you are not.
Yeah.
Papa, no, not at all.
May I comment on that?
Yeah, sorry.
I think I've done more bilateral cataract surgery than anybody, or immediately sequential, about 12,000 now. And I have had about 5 or 6 patients in whom I deferred the second eye for one reason or another. Actually, in all of them, except one, it was not because of anything wrong with the surgery. One of them, there was a dropped nucleus in the first case that we postponed it. But in the other ones, it was something else with the patient. So one of the patients I did, when you talk about stress that the patient may have, well, you know, I have the patients come to me, and because I don't examine their hearts and lungs, I have them have a note from their doctor that they're healthy. Well, I had one patient a couple of years ago who lied because he'd been elsewhere in Toronto and no one wanted to do his surgery because he was in hepatic failure. So he lied to us and went into one of these walk-in clinics where you can get a note just saying you're okay. They just check your blood pressure. And he came in with this note saying he was perfectly fine. So we brought him in there and we got him ready. And as I started to do his surgery, the anesthetist gave him a drug to calm him down because he was nervous. Promptly, he became unconscious and got a cardiac arrest. Nevertheless, I can tell you that it was very stressful. I'd already started doing his first eye and I really had to finish it. And, you know, it was kind of difficult doing cataract surgery while we were reviving the guy. Nevertheless, both worked and he was perfectly fine. So when everybody calmed down in the room, which required significant effort, I told him we weren't doing his other eye. So then we took him outside. And as I went out to talk to the next patient and sort of walk around for 2 minutes and calm down, the patient said to me, "So why can't I have my other eye done?" So I think the idea that the patient will be so stressed if you defer the second eye, it just isn't true. And the patient, even the one with the dropped nucleus, they really weren't concerned at all. They said, "Oh, thank you for deferring the other eye if you were at all concerned." I give them all a note in advance saying that if there's any concern whatsoever with anything, we will defer your other eye. And concerns can be things like unable to find another OVD from a different batch because we didn't get a supply, or a problem with the patient's general health, a sore back, all kinds of stuff. There are many, many things, and most of them aren't really from their eye. So I think it's not really a concern, and no one really gets excessively stressed. And all the patients whom I did defer for one reason or another, they kept asking me how soon we could do the other eye and wanted to do it quickly because they were fine otherwise. So I think it's one of the things that we overreact to, we worry about too much.
Yes, I think these points are all very important and valid, and it's really good that we have all this information out now in a very systematic way, with also lessons and guidelines as to how to proceed. I would like to add a few more points that there are in fact situations where you have children who have very high risk for GA. They may be a 3 or 4 month old baby and may have a heart condition and a totally white cataract. And in that situation as well, one has had to do immediately sequential bilateral cataract surgery to the extent that sometimes we even change the surgeon apart from all the other things about the separate sets, etc. So yes, there are situations, and with experience like yourself and what Christopher and other people have brought out, certainly it eliminates that situation where you can be sort of said that you're doing something wrong. So that's the first thing. And the other concern which Dr. Chaudhary had is another important thing which we should be aware of, and it's very important to engage the patient and the relatives in this discussion. If, for example, Lasik surgery as well, we almost always do both eyes on the same day, unless of course there is some situation where we're not sure about the outcome. Sometimes you have PRK which has to be done, and then I will tell the patient, let's do one eye first and then you can see how it goes. And so there are situations where you have to balance, but I think all these concerns are important, and it's certainly a very good strategy to consider. So thank you very much.
I have one question, one last question.
Dr. Richard Packard wants to speak, Sanjay.
As Steve and Chris know, I've done bilateral same-day surgery for a very long time, maybe not quite as long as you, Steve. But one of the things that's in the UK, which has come to pass as a result of the COVID pandemic, is that there are serious considerations for making this routine. And Chris will know this as well, because patients fear coming to hospital more than once because they don't want to get the virus. I think the other consideration in relation to this is if you are operating on patients and giving them a premium lens, particularly a multifocal lens, you do both of them on the same day, they're going to recover infinitely quickly, more quickly than if you do them in a separated fashion, because they're not spending their whole time comparing one eye with the other. The neural adaptation process kicks in with both eyes immediately. And I did this for years, and patients would say to me, oh, my friends say I can't do it. I said, believe me, you'll be much happier doing it this way. Finland has used bilateral same-day surgery forever. Sweden, it's done a lot. I know Steve introduced this into Canada and South Africa and the Canaries. There are lots of places where it's being done. Steve, you initiated a paper that all of us contributed to, who were the founder members of the Isbcs Society, whereby we pooled all our data and showed that the risk profile of doing this was actually, because of that we took extra care, was actually better than doing the eyes separately.
I agree 100%, Richard. And in every paper you review, the risks of bilateral surgery are lower than the risks of unilateral surgery.
Yep.
And particularly with multifocal lenses, like you said, and others, the patients do much, much better.
Yep.
And when you start doing immediately sequential bilateral surgery, it doesn't take long before all of your patients demand that you do it to all of them. Because when they sit together in the waiting room the next day, the patients who had unilateral surgery are often angry. How come that patient can now go drive, return to normal life, and I have to come back in a month? And that you hear over and over again. And I've had patients recently, because I do mostly bilateral surgery, and some patients tell me that they're really wildly nervous or whatever and want one eye done. And I've had many, many of them come to me the next day when we're seeing all the post-op patients. They all come in together and they say, why didn't you convince me or force me to do bilateral surgery? The other patients are all fine. Walk in here, they can read, they can go home and drive their car in 15 minutes, and I still can't because my other eye isn't very good. And I say, look, you asked me to do one eye, so I did one eye. But you wonder, because we walk this fine line between coercing patients and trying to convince them what's better for them. And the other thing that happens is... Pardon?
What example which you took of a patient with a dropped nucleus and you decided not to do bilateral?
Well, that patient was 100 years old and she had bilateral, dense cataracts.
Yeah.
And
So now
she
in the
wasn't a
same
candidate for
case,
surgery twice. Pardon?
so now in the same case, he had a dense cataract, bilateral, one eye the nucleus dropped. Shouldn't that be a situation where you should do the other eye so that he should get some functional vision till you manage the nucleus drop later on with the retina surgeon? Why
Yeah, but the
postpone
patient
it?
could see. Remember, the patient couldn't see anything when they walked in. But the nucleus dropped, and I put a lens anyway in the eye. It just mattered of doing a vitrectomy later. Put them on
So,
steroids. The patient could
so
see like
immediately we
20/60.
move on to the second eye and do the second eye, and the nucleus is continued to be managed because that patient may take a little longer to recover.
So Sanjay, I can't figure out whether you are for bilateral surgery or against bilateral
I'm
surgery.
in between.
Which side are you on?
You changed your stand,
So I think we're going to have to do
Dr.
another.
Tityal, sir, I think Dr. Tityal, sir, we'll have the word from you and then we shift to the other topic.
No, I have no objection on bilateral surgery, but as Christopher nicely pointed out, it has to be a institution which is geared up for this type of surgery, and that is, I think, one of the most important things. And second, the surgeon himself should also be competent enough to do these things. So if these situations are there and patients are willing, I don't mind practicing a bilateral surgery in age-related cataracts also. As Professor Radhika talked about pediatric cases, that we do sometimes. That is some sort of compulsion. But one more important thing, which I think in Indian situation is important, is a legal issue, because you might do hundreds of thousands of cases, and if you have one case getting a little difficult in terms of post-op outcome, that patient can take you to the legal side. And that regard, we need to have a definite documentation or some sort of a guidelines legally that you are safe to do a bilateral surgery. I think that is the most important aspect which I am worried about. We do practice. There are no significant literature or guidelines to not to suggest to do a bilateral surgery. So that has to come out. I think you being an AIOS chair, some guideline can come out in this regard, so that all people who are doing bilateral surgery, even a one case goes wrong, you can imagine today the type of media we have, and you can your institution can shut down. So I think
In
Dr.
fact, why
Tityal,
AIOS?
Dr.
CRS
Tityal,
or ACRS could help in this by bringing out something, a guideline.
I think
So that,
ACRS
so that
already has publications. In JCRS, the publications are there.
but
By
no
all the
guidelines.
people, yeah, all
If
the
they
They
would come
won't
out with a
publish guidelines.
guideline, it would help the whole world community.
Dr.
They won't
Bharti,
publish guidelines. But I can tell you, I've been a expert witness in 3 cases that have been sued for bilateral surgery. In every case, the basis of the suit had nothing whatsoever to do with the fact that it was bilateral surgery. And that was the essence of the testimony and discussion. And I can tell you that none of those cases got anywhere by accusing a doctor of doing bilateral surgery inappropriately. And I think it's a worry that we have, and I had in the beginning, that is greatly exaggerated. Because the complication you get is a complication in one eye. Now, if you had a really bad issue with the first eye and went on and did the second eye and got the same problem, then you are likely in trouble. But one expects it as a surgeon that you're somewhat ethical, and you would not do that. Beyond that, I don't see any issue. I've done a case in Australia, 2 in the United States, some in Canada. They just weren't issues.
Sir, our experience with the Indian legal system is that the judge doesn't know much about things. And he
The
asks
same
for a
everywhere
document.
else.
everywhere, I think, everywhere, I think. Dr.
He
Bharti
asks for a
wanted to say
documentary
something.
proof. You have some guidelines or something written which says you
Dr.
can do it
Bharti
bilateral.
wants to say something, yes.
Yeah, Dr. Bharti.
I want to say 2 things about the legal issue. One is the Baylor's law. All of us know that what a doctor is doing has to be the best according to his capability. And the second thing is you are only in a hot soup if you have a bilateral endophthalmitis, because that is the thing which is there in the book saying that, and Ray, the percentage of people getting endophthalmitis is more than, increased by about 1.5% or something of that sort. So if you get a bilateral endophthalmitis, then only there's a problem. If you get one eye problem, then the bilateral simultaneous or sequential surgery is not blamed by itself. So those two things are very important. And as a rule, when I do a multifocal or EDOF IOLs, I insist and guide the patient that I want to do both the eyes together, because as Professor Ashanov said, and Mr. Packard also. So all these factors are very important, that these things are not, the patients recover faster when you have multifocal IOLs. So I think it's all said and done, legal issues are not so important unless you have severe or serious complications.
Why can't the aggrieved party try to convince a judge that the doctor got greedy? He didn't want to give up.
I think Sanjay will move to the next talk, because
right.
We can have a whole debate, whole session on bilateral cataract surgery.
So thank you so much. It was a wonderful session. Enjoyed it.
Yeah. That's why I asked Christopher to put it in the end, but it's fine. It started off. Next talk, Dr. Radhika, would you like to?
Yes, so the next talk is another very important topic, and something that we encounter every day, and something that one all aspires to: Spectacle Independence of the Century in Modern Cataract Surgery by Dr. Ashraf Ania.
Thank you so much for the invitation, and it's very difficult to talk after Steve Arshinov and Christopher Yu. It's very difficult, so I'm trying to do what can I do. So I'm going to take you from outside to inside to remove what's outside the glasses, and to do everything from inside. I'm going to share my screen. I hope you can see my screen well.
Yes, screen is very clear, and your voice is very clear as well.
Okay, so in this talk, I'm going to say about what we have now, what we have negative, and what we have in positive, and what we are expecting in the future. I have no financial disclosure about my presentation, but I am a consultant to Crystal Lens and Biotech, and Eva, and speaker for Alcon and Novartis. So the human eye is one of the most interesting anatomical structure in the body, despite our collective zeal for removing and replacing it. Occasionally, we should step back and marvel at this masterpiece. In this world, this is the constant state of technological evolution. How can we give our patient access to the future improvement in the lens design? In some point in the future, we will likely solve the puzzle of accommodation. What this means, that if we can routinely provide 5 to 10 diopter of accommodation with the lens that's adjustable through non-invasive means, so we are going to have reached the new plateau in refractive cataract surgery. So what we have now, what the pro we have now in our hand to make the patient spectacle independence. The pro is, this is reducing the lifetime cost of glasses and contacts. The multifocal can decrease your need for reading glasses or computer glasses after cataract surgery. It's more freedom also to live actively and unencumbered. The multifocal gives improvement for near, intermediate, and far distant vision by all means of its types. And there is no upkeep or routine replacement necessary. But we have cones still now. There is a still difficulty in seeing close object, and sometimes we need reading glasses. And also the night vision and halogen glares is still present in a lot of lenses, and we should move these problems. When we look about what we have now, about the defocus curve and the MTF, you can see that it's very different you can see the monofocal, there is a steep reduction in the defocus curve compared to the multifocal, but still there is a gap between when you change between far, intermediate, and near. And also, if you look about all defocus curves and the MTF, most of the available, you can see that still there is a gap that make the patient not happy. Maybe some lenses in the market that makes the division from the intermediate to near, there is a complementary MTF that decreases the gap between the intermediate and near. But this must be a binocular defocus curve, but uniocular no. And also still there is a gap, as we said, in even the accommodative lenses between the intermediate and the near. So when we think, what is the perfect lens? The perfect lens is approaching non-invasive adjustment of the IOL power through a different mechanism. And the companies developed have found a way to alter the power of the hydrophobic IOLs through a technology called the phase wrapping. In this process, a femtosecond laser applies a pattern of spots to the lens, thus creating a lens within the lens using the Fresnel optics. And the laser engine changes the relative hydrophilicity of the acrylic lenses, thereby changing the refractive index. And also this technology can theoretically be used in any hydrophobic acrylic lenses, and it has been shown to create a highly accurate power changes up to 3.6 diopters. It corrects sphere cylinder. This technology pans out and it could be disruptive the IOL industry, and the desired characteristic could be written into the lens post-operatively. To do this, you need a trustable IOL calculation. And what's coming since 2017, the IOL cone, which I believe that is one of the innovations that can providing a personal optimized constant for each surgeon. You can send your data and they can send you back what's optimized IOL for you. And this is very good new innovations. What lessons we have learned till now? Till now, there is a high quality diffractive multifocal IOL. Surgeons and patients have an abundant choices from several manufacturers. The biggest lesson that we have learned is that in order to succeed in refractive cataract surgery, surgeons must understand themselves and their IOL preferences. Lesson one, not all patients are good candidates for multifocal. This is very important. Lesson two, surgeons should precisely understand their own outcomes. Lesson three, surgeons should know their patients. This is very important. Ophthalmologist should talk to the patient and take time to choose what is the perfect for the patient, so the outcome will be glasses independence. And the surgeon should know all their preferred and non-preferred IOLs. One of the best ways for in this modern cataract surgery nowadays is the mini mono vision in modern cataract surgery. And with our new innovation in the monofocal IOLs, like the thickness enhanced, you can do this very easily if the patient does not, or his job does not make him to the trifocal with all the halos and glare. And this can do for near and to make one eye a little bit myope, up to 0.5, 0.75, and the other eye with the eye hands can make you easily for the distance and intermediate. And these are the last publication for this lovely lens. I usually use it since 6 months. But there is a next generation of fire coming in the pipeline. The future is the post-operative changes, the light adjustable lenses, the stage 2 is recently introduced in the clinical practice, with the first result being very encouraging, and other methods of altering the power of already implanted IOL is under development. And also the same for the future, the same can be said about the correction of presbyopia and so-called the frontier in refractive surgery. Also, there is a huge innovation in the extended depth of focus nowadays, and has a technology in the pinhole IOLs. And there is also several technologies currently being tested to achieve finally an accommodative IOL. Another new innovation coming in the future is a clear view. It's Merck is developing yet another technology called the Lacry Eye for the post-operative lens adjustment. This technology is based on a property reactive is a mesogen material called the Lacry view. The mesogenes are a compound that displays properties similar to those in the liquid crystals. And this material is flexible and has been used in other applications like the LCD and OLED display to help improve the optical quality of images. The mesogenes can alter post-operative using a non-invasive methods that have not been fully disclosed as we see in the figure. As we said, there is a light adjustable lenses, but we have a lens filling technology like the smart IOL, the Medunium, using a solid rod of thermodynamic hydrophobic acrylic material that soften at the body temperature to transform in about 30 seconds into a biconvex soft gel material, 9.5 millimeter wide, from 2 to 4 millimeter thick, that completely fills the capsule and has precise dioptric power and dimensions. Also, we have in the bag accommodative IOLs that's coming in the future are another very exciting perspective with many new technologies, the anteroposterior movement giving near and distant vision with a single optic IOL, such as the crystal lens from Bausch & Lomb, and the human optics, also the lens tech. Also, there's a power, the module of the IOLs with a monofocal based lens and fluid optic accommodative component, which is the Lensigene. Another artificial intelligent lens, which is the Sapphire IOL, the Elanza, which is an electrically controlled, remotely programmable, customized until artificial intelligence to auto-adjust the focus in response to changes. And I think this will be a great change in this technology. So my conclusion say that the future is coming. Perhaps it is already here. We must do everything in our power to leverage the collective creativity of the physicians, engineers, and materials science to continue moving the needle. The human eye, the human lens is a work wonder, and we need better design to mimic its nature, function, as well as less invasive ways of correcting refractive misses. We are all amazed at the advances that we have witnessed in the last 10 years in ophthalmology, and I think we will can't wait to see what's waiting for the 20 to 30 years coming. And I'm hoping that my patient whom I'm operating today will have the opportunity to use those technologies and to be coming available for them. Thank you for listening.
Thank you, Dr. Asher. That was a wonderful presentation. Any questions, anybody in the panel?
I have a comment, I guess. That was a really wonderful presentation. And like you, I'm waiting for the future. I must confess that I have not been particularly happy with the vast majority of multifocal or EDOF lenses that we have, partly because I look at myself one day getting older and needing cataract surgery. I have the privilege of, for my whole life, having had better than 20/10 vision. The only lens that remotely gives close to 20/10 vision is the monofocal Tecnis lens. And actually the silicone one was better than the current acrylic one. So I don't look forward to having to have cataract surgery. And that's why I wear glasses, because I don't want to do anything to make me see 20/25 or 20/30 when I currently see 20/10 or better. Actually, I can read the 20/10 letters through the mirror in my examining lens. I probably see 28. And I think a lot of us do. Ophthalmology tends to select out people who have Top Gun vision like me, and we don't want to have our vision decreased. And I hope the new focusing IOL, particularly the one that's electronic, offers a benefit for the future. So that was a great talk and I really enjoyed it, and I'm hoping it works out fast.
Thank you so much. And really agree with you that most of the EDOF lenses are not going well, and most of my patients are not happy with this technology. Maybe the trifocal makes better than the EDOF. But the most of the people that I did the mini monovision for them, especially with the new monofocal, are happier than the trifocal IOLs that I did.
So EDOF has the only advantages that they don't see that circles and halos because of the rings. But yes, not everybody is landing in a perfect 6665 situation.
This is true. This is true. The EDOF lens, the most difficulty in EDOF lens is that the intermediate, that the near vision is not well, and the patients. This is why I said that you need the more time with the patient to choose what type of your patient and how you are going to remove his glasses. Because if it's already near glasses, so he's going to use the near glasses. It's not logic to put him in EDOF lens.
So the ophthalmologist should use an EDOF lens or not use an EDOF lens? No.
No. No.
For their own eyes. Correction, for their own eyes.
Dr. Richard Packard wants to say something.
Yeah.
You know what? I think that the argument we haven't really come to is what you tell the patients in advance. Because by and large, if you tell patients in advance what they're going to get, and then they get it, then they're pretty happy. If you tell them in advance that they will not be able to read without putting reading glasses on, but they will have good distance and intermediate vision, and that's what they want, that's fine. If they say they want to have the full range, then you have to go through all of the caveats that we know exist with trifocal lenses. And if you don't do that, you'll have miserable patients. And it's as simple as that. Time spent before surgery saves time after surgery with these patients.
So true. So true.
And I've also had very good results with monovision because it doesn't decrease their acuity. And if it does, and they want to watch a 3D movie, they can put glasses on for the 3D movie.
Yeah, there's a point here as well, is that if you put an aspheric monofocal lens into somebody going for distance vision with both eyes, and you really nail the biometry so that they're seeing 2015, 2012, they're not happy. Do you know why they're not happy? Because they can't see the food on their plate without putting glasses on. And this is where the new EDOF lenses give you a whole new range, because these patients may not see absolutely crystal clear in the distance, but for most purposes, through most of the times that they're going to spend in their lives, they can actually have a good functional level of vision. And I think that's the difference between trying to get full correction with a monofocal lens and using lenses like Eyhance and Vivity and so on, and all the new ones that are coming out, they're all trying to do the same thing.
So, sir, the conclusion is that the ophthalmologist should not use these EDOF lenses in their own eyes, but in the patient's eyes, it's acceptable.
No, not at all. I would be happy to have an EDOF lens and have a bit of mini monovision. I think it would give you a good range of vision, and you would also know that you wouldn't get significant dysphotopsias.
Yes, I would like to say that we cannot make it so simplistic that an ophthalmologist should never have this and never have that. It's just a question of understanding. And when you're having this discussion with the patient, often what you're saying, the patient doesn't absorb it fully. And one very important thing additional to what Dr. Packard mentioned, Mr. Packard mentioned, is the cell phone. Because you say near vision, but the patient doesn't put that. I mean, cell phone is so much a part of their life that they don't realize. And then if they can't see the cell phone without glasses, then they're very unhappy that they have to put on spectacles just to read the cell phone. So, I mean, just to dial a number or whatever. So this is important to have a little discussion as to what's their life like and what do they need. A person may prefer that they should be able to see the phone, etc., without glasses. They wouldn't mind seeing 612 or 69 in the distance. The other thing is some people who aim that they want both distance and near, you have to explain that the brightness or the light is divided between both and they're constantly actually seeing both. So you do, as you said, you do have to spend those extra minutes before surgery. And when you're having that discussion, you have to also see if you're mentally connected with the patient, because they may say yes, yes, and they may agree, but they're not really understood it. So it's a very complicated, and I must say, if you have technology where the actual power of the lens changes rather than just giving distance and near in one small plastic piece in the eye, as has been shown, that would be something which would be really futuristic, and let's hope it happens. So with that, we can go to the next lecture, which is a very important, again, intracameral pupil dilation. I must say all the talks have been wonderful, and this is another aspect of cataract surgery, which we would really love to hear from Dr. Steve Ashnoff.
Thank you, Dr. Tandon. I'll just share my screen. Okay, hopefully you can all see this. The meeting has been phenomenal so far with great discussion, and I'm going to talk about one more thing which I think is very important to all of us. And with the only warning is when we discuss intracameral pupil dilation, that everything I say is off-label in case any Americans are listening, because everything is off-label in the United States. So my disclosures are there, none of them apply to this particular talk. So I've been doing intracameral dilation for many years, probably 15 years. And the question is, who needs intracameral dilation? Well, I found out, for better or for worse, by just being a surgeon for a long time, that just about every time I do the first case in the morning, the patient is not that well dilated. And then if you have patients that have IFIS, you know that brown eyes are not nearly as bad for IFIS as blue eyes, which I guess is advantageous if you're in India. But in the kind of practice I have, where I have people from all over the world, in Canada, which Toronto is the most cosmopolitan city in the world, I get brown eyes, blue eyes, everybody. And the blue eyes dilate easier if you give them intracameral topical drops. The brown eyes slower, but the brown eyes don't get severe IFIS. So those cases also benefit a lot from intracameral dilation. All other kinds of small pupils also benefit. I advise you all to learn how to stretch pupils and use OVDs. It's much easier than using hooks, and you rarely need to use hooks or rings if you use OVDs and stretch pupils, even in IFIS cases. And then you have pupils that shrink during surgery. And one of the most obvious ones are if you do femtocataract surgery. In every patient in whom you do femtocataract surgery, the pupil will shrink after the femto, and giving intracameral dilation after the femto makes life a lot easier. And what I do now is I do this for every single case I do because it just makes my life much simpler. So let's talk about the drugs. Well, the first one is intracameral lidocaine, which is probably the first drug any of us used for intracameral injection. And we have chemical requirements for intracameral lidocaine. It must be preservative-free, isotonic, and pH balanced. I think the most common one in the world are the Astra 1% polyamps, which come from AstraZeneca with their recent fame and concern about their vaccine. But they've made this polyamps of 1% xylocaine, which are fantastic to use, and I've used them for years and years. The beneficial effects of intracameral lidocaine is it reduces iris pain to essentially almost nothing, and you get a pronounced mydriatic effect by paralyzing the iris sphincter. So then we have cyclopentolate and tropicamide. Cyclopentolate is popular, but it has a slow onset and it has a very long effect. And if we give it intracamerally, it lasts 36 hours, which is why it's not used in the intracameral dilating drops. People use tropicamide, which has a more rapid onset and a shorter duration of effect. This is used in Midrain, made by Thea Pharmaceuticals, originally from France. But when you look online, you get an address in England, which I'm not sure why. Maybe I found a British website. And Phenylephrine Plus, sold by Intel in India, is a copy of Midrain and has also tropicamide in it. Epinephrine was used by Americans, it still is. It's a non-specific sympathomimetic agent. It's used as an additive by just about all of us for the irrigating solution. We give 0.5 mil of 1 in 1,000 epinephrine, and that gives you a 1 in a million concentration in the irrigant, which prolongs the effect of the topical mydriatics given preoperatively and prevents intraoperative meiosis. The problem with it is it has a preservative bisulfate, which is added and thought to be toxic if the concentration exceeds 0.05%. So all of the epinephrines that contain bisulfate are not good to use intracamerally. Epi-sugarcane was made by Joel Sugar, which is a combination of preservative-free epinephrine made in the US and lidocaine, and has been shown to be safe and effective and is used by many Americans. Phenylephrine is a more recent one than epi-sugarcane, and phenylephrine is an alpha-1 selective sympathomimetic, and it has a great effect on the pupil dilator. The mydriatic effect occurs topically very slowly because it has poor corneal penetration. But with intracameral injection, it has an extremely rapid onset of effect and duration. And within 20 seconds, you get maximum dilation of the pupil. And the Swedish mixture was the first, started in about 2003 or 2005, of intracameral phenylephrine 1.5% and lidocaine 1%. Mydriatic effect is greater with epinephrine and epinine compared to phenylephrine, possibly due to the additional stimulation of the beta-adrenergic receptors, but phenylephrine has the advantage of being more stable in a solution and an acceptable pH for intracameral injection, so people often prefer to use it because it's more stable and safe to use. So the first time these were proposed were xylocaine phenylephrine was first proposed to be used together by the Swedes, by Lundberg and Bendig, who published this paper in 2003, and showed that within 20 seconds, if you use this combination of drugs, you got maximum pupil dilation, which was very impressive and encouraged all of us to try to use it. They then, a number of years later, has published a second paper in 2010, which showed that if you use 1.5% phenylephrine or more, that you got a much better dilation than using less than 1.5%. But this study was done using phenylephrine alone and not mixed with xylocaine. You get a synergistic effect when you mix it with xylocaine, and this graph doesn't quite hold. And then Gurbaxani and Richard Packard, who's listening, came up with a brilliant idea, which is extremely smart, that you can take the minims made by Bausch & Lomb or sold by Bausch & Lomb, but made by somebody else, and you can dilute it. And when you dilute it, you get a very good reaction using the phenylephrine, and you don't get sufficient bisulfate to be toxic. Now, Bill Myers in the US has intracameral phenylephrine made up for him by lighters, and Ramon Laranti has it made up for him in Spain. I think he also buys it from lighters sometimes. So it's becoming very common for many of us to propose using it. What I've been doing for the last 15 years is taking a minim of xylocaine phenylephrine, 10%, and adding it to 5 cc's of balanced salt in a 6 cc syringe, which dilutes it to 0.57%. And then what I do is I add 6 or 10 drops of this to the non-preserved xylocaine polyamp from AstraZeneca, and I get about 0.1% solution, which is 100%, 100 times diluted. I take the solution, I inject it as a first step of surgery, 0.1 to 0.2 cc's through the side port, which I make first, and then I inject it under the OVD again, which gives me another millimeter or so of dilation and makes it work better. The advantage of using a lower concentration is you can inject a bit more. You don't have to restrict yourself to the 0.2 cc's recommended by the manufacturers of the commercial products with higher concentrations. So here's a patient who I was told got dilating agents, and this was the first patient in the morning. And so I injected the intracameral xylocaine and phenylephrine. And if you watch, you see that in no time, in 5 or 10 seconds, you start getting really excellent dilation. And you no longer think you're in for a nightmare. It looks like a regular case. The pupil dilates well, and it's not going to be a problem. So this is how it works. It's really amazingly effective in surgery. If any of you want to use this, my solution, if you email me, I'll give it to you. I'm not trying to sell it, but I'll tell you how I make it and how I use it. This is a comparison of the commercial products. The Midrain was the first commercial one sold in Europe, and it has Tropicamide, phenylephrine, and lidocaine. The solution that I've been making up for years has this, which is close to this, but doesn't have any Tropicamide. Phenycaine, made by N. Todd in India, originally copied my solution exactly, and then they copied Phenycaine Plus from Midrain a couple of years later. I think both of these are now for sale in India and in Southeast Asia and many parts of the world. All of the commercial ones recommend using 0.2 mils and not more. And if you use my solution, you can inject it as often as you want because it's quite safe. The one that's interesting and the outlier is Omidria, which is sold in the United States. It has 1% phenylephrine and 0.3% ketorolac. It comes in these vials, which you dilute with saline when you make it up, and you put it into the irrigating solution. The amazing thing about this is it costs $465 US per vial, which is a pass-through cost in the United States, but is more than we get for the entire cataract surgery in Canada. And I'm sure that it's way more than you get for cataract surgery in Southeast Asia, India, or most other places of the world. So what amazes us in Canada, just across the border, is that Americans will pay this for it when you can do it for a couple of dollars or less by using the other agents I talked about before. So the summary is that I think we should all use intracameral dilation because it's more effective. It makes your surgery much easier, particularly if you do femto. You can get into trouble with femto when you do the femto, and then as you get the patient in the operating room prepared for surgery, you find the pupil is smaller than the capsulotomy, which is a problem, and this totally corrects it. It's simple to make up xylocaine phenylephrine yourself. If you get the minims from Bausch & Lomb, which are available everywhere in the world except for the US. Europeans use Midrain, and Indian and Southeast Asians often use Phenycaine or Phenycaine Plus. So I think it's not a problem. We wrote this article with the American Academy on perspectives of all the intracameral agents that are available for use in the eye. So I hope that was helpful. Thank you very much. And thank you for inviting me to speak.
Thank you, sir. That was a very enlightening presentation. I've had the occasion to use some of these Phenycaine pluses in India, and I found a very good response. The pupil dilates very well. But my question is that our personal experience, that the kind of dilation I get by using Phenycaine plus versus the kind of dilation I get by using the drops pre-operatively and having a nice strong dilation, which is persistent. I somehow find that the element of using NSAID does add an element of sustained dilation, or probably a 0.5 millimeter more dilation than what we would get by just using an intracameral Phenycaine plus. Your comments, sir?
I agree with you 100%, but I don't think it's only the NSAID. I think it's because you do brown eyes. Brown eyes are very different from blue eyes. When you give these drops into brown eyes, the drugs are absorbed by the pigment. So when you give an intracameral injection, at least half of the drug is absorbed by the pigment. And I notice in patients in whom I give only intracameral that they don't get as much dilation as if you give them some drops preoperatively well and allow it to diffuse in and to saturate the granules of the pigment before you give intracameral. So I do both. We don't do a lot. We give them drops twice before surgery, when they walk in the door and 10 minutes later, and then bring them in 10 minutes after that. And I find that they do better if you do both. So as in many, many things in ophthalmology, when we have something new, it doesn't mean you should abandon everything else you've been doing.
I agree with you 100%. So it's a great tool in the hand of a surgeon. When he's seeing the pupil constricting, he can just go in and bring it back to its almost near dilation. But the combination of pre-op and intra-op makes a wonderful tool in the hand of the surgeon.
What? I should just add that that doesn't really happen much in blue eyes. In blue eyes, you get a phenomenal dilation right away, and it doesn't make much difference. But I doubt that in India you do many blue eyes.
Oh, very good.
I do mixtures in Canada. You get to see. It's actually fun to see the difference between a blue-eyed patient now and a brown one next, and often we'll have a person from Ghana, one patient, then one from China, then one from Northern Europe, and all in one day, and you see the different reactions to the same medications. And it becomes obvious that the pigment matters a lot. Same with IFIS, it's a huge difference with the pigment.
I think there's a multi-center trial which is going on with Phenycaine and Phenycaine Plus across 6 or 7 centers, and I think the results of that would come out, and I'm sure what Dr. Steve Ashnoff is saying, that the color of the iris will make a difference to how it responds to the intracameral agents would be there definitely.
What I have been using in the last about say 10 years or maybe more is a combination of 1 part of adrenaline, 2 parts of atropine, and 3 parts of lidocaine, preservative free, all 3 preservative free. And that gives a very good and a dilation which persists even after the surgery for next couple of days. So it's a very strong dilation, and the pupil doesn't come down. That is what I've been using. I've used Phenycaine, and I agree fully that all those pure intracameral will not dilate as much as the topical plus intracameral. But when I have a patient who is hypertensive and I don't want to use a topical, and in those cases, if I do intracameral, the blood pressure doesn't rise, and also the dilation is persisting throughout the surgery and even after that. So I have tried that, and I welcome all of you to try this and see what kind of result will, because Phenycaine by itself does not dilate that much. I agree. Thank you.
So my impression was that why not use Tropicamide plus an NSAID preoperatively? Don't use phenylephrine preoperatively because of the risk of the rise in blood pressure. And intracameral use phenocaine plus because that short spurt and it immediately is out of the eye when you do your surgery does not cause the blood pressure to rise immediately during surgery. And since the surgery period is short, 10 minutes, you don't have the surgical BP problems as you would have otherwise.
I do the same thing. I don't give the patients preoperative topical phenylephrine.
So
I only give them the intracameral. By the way, another effect you have with brown eyes, when you don't notice a very good effect by giving them intracameral once, give it to them twice. Give them give the first injection to saturate the pigment granules, and give them one after you put the OVD in. Another injection under the OVD, and you'll get more dilation as if
That's a
you
wonderful.
gave them pre-op
I must
topical.
try this out. Yeah, this is a great suggestion. I'll try it out next
But
time.
I don't like the atropine because that's what makes it last for 3 days.
Yeah.
And I do 90% bilateral surgery, and my patients would complain about halos and not seeing well if they were dilated for 2 or 3 days. I actually give them pilocarpine at the end of surgery. And so by the time I finish the second eye, the first eye's pupil's already small, and they can get up and they can see fine to walk around and do things. I don't patch them at all, by the way. I just tell them to wear glasses. We give them these glasses to wear because I want them to see when you do bilateral surgery.
Perfect.
So Radhika, Dr. Radhika, you can invite the next speaker.
Yes, so we now come to a very important lecture on the pandemic prevention of postoperative endophthalmitis. It's a plenary talk by Professor Christopher Liu. Looking forward to hearing your thoughts, Dr. Liu.
Thank you very much. The reality is that there isn't much new to talk about, but I will share with you my thoughts. For sure, I will do that. So pandemic prevention, post-phacoemulsification endophthalmitis. I don't have any interest to declare. Prevention of endophthalmitis during the pandemic is essentially the same as in peacetime, except for two differences. Firstly, the practice of wearing face masks, not just on our part, but also on the patient's part. Secondly, the pandemic affects how well with endophthalmitis. It's similar to the story of bacterial or acanthamoeba keratitis that I have actually been advising during the pandemic, that contact lens wearer may perhaps avoid wearing contact lenses and just wear the glasses, because what if they develop a serious infection and we as ophthalmologists are less able to look after them because our nurses are depleted or redeployed, and some of us have become ill, and some very unfortunate colleagues have even passed away. So those are the two differences, really, a patient wearing masks and our decreased ability to look after patients with endophthalmitis, which, as we know, time is of the essence, and bacteria multiply very, very quickly within the warmth of the vitreous. These are the steps which I will revise with you for reducing the risk of endophthalmitis. So if there is any external eye infection, if there is florid blepharitis, or if there is any blocked tear duct, then deal with those before phaco surgery. And remember the magic of povidone iodine, which kills nearly everything apart from a few strains of fungi. They do need time to work. So let's say we should put the povidone iodine drops at the same time as your proximethicane or local anesthetic drops, so they get to work for a few minutes. And you might instruct nurse to put some in under the lower lid as well as under the upper lid. Now, when they come into the operating theater, we clean and sterilize with povidone iodine again. Usually in most countries, 5%. And the reason for that, it's when you dilute the iodine, you actually get more free radicals. However, when you dilute too much, then you do not have the reserve for continued action. So I am quite exuberant with my use of povidone iodine, and I will put it on the upper part of the face on that side and lid margins, and then I use the cotton ball to evert the upper and lower fornices to get some iodine in there as well. And sometimes the patient will say, oh, it's really stinging. And then I have to go back to the anesthetic nurse and say, oh, you haven't been putting the anesthetic drops in the upper and lower fornices. So when the iodine reaches those areas, then it stings the patient's eye. Well, what about allergy to iodine? I think we should go through the formality of a patch test on the skin, because iodine is so much better than the alternatives, for example, chlorhexidine. Now, here we have a picture board from a past Royal College of Ophthalmologists president, Nick Asbury, and he's showing you how to put a drape on, and we drape onto open eye, having first dried the skin so that the drape would stick properly. Now, the advantage of draping onto open eye is, if you're lucky, all the lashes are actually the lower ones pointing downwards and the upper ones pointing upwards, and you cut in the middle, and then you put the speculum in with the lower part going underneath the lower lid with this part of the plastic. So it's like properly tucked in, and where the lid margins, where the bugs are normally, they are actually excluded from the operative field. Now, there should be no communication with the nostrils and the contralateral eye. So if I can be very critical, and I say, look, this part of the drape has actually not stuck. So it's in communication with the other eye, and in turn, it might be in communication with the patient's breath. So having done that, then I'd say turn the face slightly to the side of the operation so that fluid does not pool and it drains away. So here, I want to bring to your attention the importance of avoiding moisturizer or face cream on the day of surgery. And the reason is because when you have this, the drape may not stick and it just slides around and your infection risk goes up. So I have noticed that there are some telltale signs. The first is when you look at a patient and the skin looks so nice and shiny, and you have to ask them, what did you use some moisturizer or whatever? And then they will usually say, yes, but the letter didn't say that I couldn't use a moisturizer. So then you send them away and say, okay, wash your face, please, with soap and water. So it's down to just bare skin without a layer of oil. Otherwise, the drape will not stick. The next time you might notice this is when you mark the eye. I think in the majority of countries, people do mark their eyes now with an arrow. And if you find that with your marker pen, the ink doesn't take, then there might be a layer of oil there. And finally, if you've missed that as well, and when you're doing your iodine, it tends to just run off, then you know that there's a layer of grease there, and you have to get that all cleaned off. The second point during the pandemic is, I think there is a consensus of asking the patients not to wear a mask during surgery. They are under a drape, so you're unlikely to be breathing the patient's breath. But if there is any leakage in the drape, then there will be misdirected breath and the bugs from the oropharynx onto the eye, which you're operating on. So there is an increased theoretical risk. So these are important points. So now going back to revision, obviously wound architecture is really important, and people will argue about uniplanar or biplanar or triplanar. However, I would say the most important factor is to have the wound long enough so it would seal properly. And be careful also not to have your wounds too tight. Obviously, if your main wound is too tight, you might create a phaco burn, and then the wound wouldn't seal properly. And your side ports for your irrigation aspiration, for those who use bimanual, if they're not big enough, you're going to end up stretching a linear wound into an ovalized wound. And because it's been stretched, it may not seal quickly enough. So again, it's better to have a slightly more generous wound, as long as it doesn't leak too much, than tight wounds, which you end up ovalizing and then they don't seal. Remember the low threshold to suture. If the eye wouldn't seal and the anterior chamber wouldn't reform at the end of surgery, and it doesn't reach a normal physiological IOP, you know it's leaking, and do a suture. If you're so unlucky to have had a phaco burn, remember to suture not radially, but tangentially, so that you don't end up causing 5-10 diopters of astigmatism. And remember, sclerotunnel is a very useful wound to lower the risk of a wound reopening, should there be any mild trauma following surgery. And also it is a much safer wound, although you would need to use diathermy and so on. And I think then for people who you think might rub their eyes and people who are uncooperative, then the sclerotunnel is worth considering. Remember the risk factors of a temporal wound, unless it's a very well-constructed one, and vitreous loss is also a risk factor for endophthalmitis and lengthy operations. And remember to use your prophylactic antibiotic, principally intracameral cefuroxime, although subconjunctival cefuroxime will also act as a good depot. Beware of overdose of intracameral cefuroxime. You're only meant to put 0.1 ml in, and studies have shown, or at least hinted at, increased risk of cystoid macular edema with overdose. The other day, I saw one of my trainees underdose 0.1 ml. What they did was they were using the same cannula for force hydrating the wounds and also reinflating the eye. And they emptied the intracameral cefuroxime to 0.1 ml, so the patient doesn't get an overdose. And then they reattached the cannula and then injected that into the anterior chamber. Then I pointed out to them that, well, you've actually got dead space within the cannula and the top of the cannula, because that's still filled with BSS. So I told them that in the future, if they want to empty the syringe of intracameral cefuroxime to 0.1 ml, that should be done with the cannula in place, because otherwise the patient might just be getting half dose. So now I want to go back to mask wear after cataract surgery. Now, if you do pad, and I know people often don't pad, before shielding, it allows you safe mask wear for the patient to get home. Otherwise, they are directing their breath directly onto their freshly operated eye. It's probably low risk, but it is an additional risk. And I think with a carefully constructed wound, you're okay. But what if it's not perfect and bugs get breathed onto the eye and you get a significant inoculum into the inside of the eye? So again, I'm being ultra careful. So I do ask patients to wear shields day and night for the first week, especially for temporal wounds. I have been criticized for not supplying glasses, wrap-round sports kind of glasses to patients. Well, why can't we supply those? And well, I don't, because apparently there's a product liability issue that if those glasses break, then it becomes my fault. Whereas if they went to buy from a shop, they go to buy from a shop, it is the shop's fault and not mine. So I generally now ask them not to wear a face mask for the first week, which also means that they're going to have to stay at home and not go out, because we have to wear a face mask for going out. So that's about the end of my talk. And I, as honorary treasurer of the college, I want to bring you some news from the Royal College of Ophthalmologists that fellowship and membership by election is still open. And also we are planning to hold clinical exams in international centers, including New Delhi. my book again. And my thanks to you for listening to me and inviting and including me.
Sir, I have a question for you. The issue of using masks during surgery. So at the start of the pandemic, when we got back to using doing surgeries, and we were very aggressive, we tried using the N95 mask on every patient before he entered the OT. And we realized that doctors can sustain an N95, but patients were not used to that kind of a layer, and they were either feeling suffocated and restless during surgery, or they were even reporting higher incidence of claustrophobia compared to what we normally come across. And then sometimes that air which is to come out from the edge of the mask could sometimes fog the optics of the microscope.
Yes.
So I just finished. So
Yeah.
we decided to take the patient and try a normal surgical mask with a tape. So that if you put a tape on a surgical mask or an N95 mask, at least the air is not coming up and fogging the optics or the area of the eye, but then the sterility of that area was questionable with the tape on. So we didn't have a sterile tape for use at that time. So probably we thought, why not pull the mask down the moment you put in the drape? First you drape the patient, stick the drape all over the eye, and then from under the drape, we ask the assistant with gloves to pull the mask down so that the patient is comfortable during surgery. And the moment the surgery is over, we pull the mask up and lead the patient out. Your comments, sir.
I think what I've done is I've brought the issue into discussion, and I think that there will be local adaptations, and also depending on whether you have screened the patients for coronavirus beforehand and whether they have been self-isolating. And now with our green screen operating, that we ask them not to see many people for 2 weeks. And of course, now fortunately in the United Kingdom, at the moment, the coronavirus rates is actually very low. So I think we have to adapt differently. But in terms of taping, I think that's a very good thing to do because it stops the misdirection onto the eye, and also fogging the optics of your 90D lens, or even fogging OCT lenses when we're taking images of the back of the eye. Yes, all very important. I suppose from what you were describing, if you wanted to, you can have a surgical mask, tape the upper part, and then you can use iodine, including on the micropore tape and the mask, and then drape on. You can do that. But I think that doesn't stop the sensation of not having enough air and the claustrophobia for the patients, because they already have a drape. And whilst the drape is on, I think the healthcare professionals are protected from direct breath. Now, in terms of aerosol formation, we can't stop that, but the air change in the operating theater is very good. Say 15 times, aerosol will be cleared very, very quickly. And don't forget, staff are also producing aerosol as well. And at any one time, we cannot be sure who is infected and who is not infected. It is the risk of being a doctor, unfortunately. That's all I have to say.
Where do we conclude that we use a surgical mask with a tape, or we pull the mask down after the draping so that the eye is in any case sealed from the breath? The mask is down under the chin.
Can I add here that we are routinely using surgical mask with the tape, and we don't pull it down. So you can try that because they don't feel that claustrophobic. So surgical mask with a micropore tape at the bridge of the nose, and then we clean it with betadine. And it's been routinely done. Patients are quite comfortable, and I think this is very important to bring it out into people's knowledge about the misdirection of breath, something which not everybody may have considered. So it's important to highlight this point. Everybody would have their own variation. But just if you want a practical experience of whether this works, it works fine. You just put the tape on the top edge of the mask and you don't need to pull it down. And then you don't have to touch under the drape, etc. So you just try it next time. You'll find it will be working absolutely good. But this idea of not wearing a mask 2 weeks after is another important point. So we'll have to talk to the patients, because honestly, we didn't bother about what was happening after surgery. And I think it's important to make the patients aware that if they're wearing the mask, then they should pinch it. And if they're at home, they need not wear the mask. So I think that's wonderful. So can we go to the next lecture? Would you like to introduce Namrata?
So the next lecture is going to be by Dr. Richard Packard, and it's a recorded lecture. Dr. Packard is already here, but he's going to be talking. The lecture would be on white cataract capsulotomy, a new approach, and then he's available for any question answers thereafter. So Nikhil, do you have it with you?
Yes, Karan from the webcom team is going to be playing it. Karan, could you please play the lecture?
Thank you very much indeed for asking me to be part of the international faculty of the Delhi Ophthalmological Society International Conference. I'm going to be talking about white cataract capsulotomy, a new approach. I do have a financial interest here, as I am a consultant to Exolens, which is the company that makes the laser I should be talking about. In 1999 at ESCRS in Vienna, I gave a presentation on white cataracts. As you'll see from the next two slides, the capsulotomy was a major issue. So this is what we were faced with a white cataract, where you really couldn't see what was happening with the capsulotomy at all. And this was the slide that I showed to give advice as to how you could better do the capsulotomy. First of all, you needed to use a high molecular weight OVD. You need to be flexible to improve your visibility, to clear away the lens fluid and hyaline cortex, and also you could use an oblique light and high magnification. You might have to restart if required. And the vitrectomy light pipe could be quite useful as well. Also, there was high frequency radiodiathermy available, which is what you can see in the picture here. And you might need to consider doing a can opener capsulotomy, because this was certainly much easier than trying to do a capsulorhexis when you couldn't see what was going on. And above all, you had to take your time. But at the same meeting, a simple vital stain, trypan blue, solved the visibility issue. This was demonstrated by Gerrit Mellis, but in fact it had first been used by Minas Coroneo while he was working in the outback in Australia. And this was my very, very first case using trypan blue under an air bubble. This is speeded up a little bit. But the important thing was that we could now see the capsule. So when I put my cystotome in there, it was easy to pick up the flap, take it round, and then you just had to deal with a hard cataract, but at least you knew you had a good capsulotomy that made it a lot easier. But seeing the capsule was only part of the story because of the intralenticular pressure in intumescent cataracts. And here we can see the original video where the Argentine flag sign was described for the first time. The eye has been filled with an OVD. I don't think it was high molecular weight, however. The capsule is now opened. Capsulotomy started, but the pressure inside the capsular bag is much greater than that in the anterior chamber, and you can see what happens. It splits wide open. The surgeons were watching this, and they noted a similarity. The similarity to the Argentine flag. And being very patriotic, they felt that it was important that they should mark this, so they saluted the flag. There have been a number of techniques described to overcome this imbalance of pressures. You could do a can opener capsulotomy, as I said earlier. You need to overfill the anterior chamber with a high molecular weight OVD. You could do a mini rhexis and then spiral it out to create a rhexis of the appropriate size. Or you could do puncture and cortex aspiration. or use high-frequency radiodiathermy for your capsulotomy. Some people have been using a preoperative YAG laser anterior capsular puncture, and also you could use the femtosecond laser to do your anterior capsulotomy. Well, what about the femtosecond laser? It gives a very precisely sized capsulotomy. It's created very quickly and the surgeon can center it, but there is a release of liquefied cortex as the anterior capsule is breached, and this may prevent creation of a complete free capsulotomy cap. But are there ways to avoid problems, and how often do they occur? Here's one method that's reported by Burkhard Dick and his team. They do a mini capsulotomy, 2 millimeters in diameter, which is created at the start to release the intralenticular pressure. Patient is then taken to the theatre and the milky liquid that spills out is removed without causing any problems to the anterior chamber. Next, the laser is redocked on the patient's eye. Then a second 4.5 to 5 millimeter size capsulotomy is created. And all cases that they've done using this two-step approach had good quality capsulotomies and a 360-degree overlap of the IOL optic. And here's another study from China where they compared manual and femtocapsular complications in white cataracts. The study was quite large in that there were 132 eyes, 132 patients, 66 in each group. Anterior capsule tears were significantly more common in the manual group compared with the flax group, 12.1% versus 0%. All 8 cases of anterior capsular tears were intumescent. 6 flax cases developed incomplete capsulotomies, 4 of which were intumescent. And laser capsulotomies were better sized and more circular, and the IOLs were better centered than in the manual group. What is surprising about all of this in terms of the femtosecond laser is that all of the white cataract cases in which femto was used, shown on YouTube, required trypan blue to see if the capsulotomy was complete. And you can see 8 examples here. Let's have a look at another approach using a laser. Selective laser capsulotomy, SLC, requires the anterior capsule to be stained with a microfiltered solution of trypan blue 0.4%. This acts as a target for the laser beam to be absorbed and thus create, using a low temperature continuous thermal beam, a circular capsulotomy. The laser has converted type 4 collagen of the capsule into amorphous collagen at the capsulotomy edge. This edge is highly elastic and stronger than both a manual CCC and femtolaser capsulotomy. In order to do this, the eye will have been overfilled with a 2% sodium hyaluronate solution. As the eye is fully sealed and pressurized, during the laser excursion, the liquefied cortex does not escape and the capsule remains stable. SLC is carried out with Capsulaser. Here we can see the laser mounted on the microscope. It has a small console which fits on a tray next to the operating microscope, and this enables you to select sizes from 4.5 to 5.5 millimeters. The capsulotomy edge is rolled over and hence very smooth. Amorphous collagen is seen at high magnification in the photomicrograph on the right. To test the strength of the Capsulaser capsulotomy edge and its tear resistance, a paired cadaverized study was carried out, and the comparison was made between flax and manual CCC, Capsulaser and manual CCC, and Capsulaser and flax. And what we found was quite extraordinary, that the strength of the Capsulaser capsulotomy was far greater than either of the other two. If you looked at the relative tear strength, and CCC was considered to be 100%, flax was 70%, and Capsulaser was 150%. And this was significant at less than 0.01. Through all the various iterations of Capsulaser, it's been possible to perform capsulotomies without any tear-outs. There have been over 4,000 eyes now treated with Capsulaser. There were 21 white cataracts reported over the last 4 years. 8 of them were considered to be dry, 11 intumescent, and 2 Morganian. The average age of patients was just over 80. There were no Argentinian flag signs in any of these cases. 62% of the caps were free-floating, 38% were free-floating apart from a minor tag which had no mechanical resistance, and there were no formal tissue bridges, as is sometimes seen with the femtosecond laser. Let's see some examples of some of these cases over the years. In all 4 of these, we're still using a patient interface, although you'll see in the latest version this is not considered to be necessary. But what they've all done is to produce a nice, round, safe capsulotomy in all of these eyes. And you'll notice in the one on the bottom right from 2020 that until the keratome actually goes into the soft lens material, none of it comes forward because the eye is fully pressurized because of the sodium hyaluronate 2% which has been used. So what is the current process to achieve a consistent capsulotomy with an intumescent cataract using capsule laser? First of all, we need to prepare the eye for the laser. That involves injecting microfiltered trypan blue. It's a very pure solution and it gives rather better staining than standard trypan blue. Because it has a specific gravity which is greater than aqueous, it falls onto the capsular surface. It's normally left there for about 30 seconds and then it's important to wash it all out so that you've only got the stained capsule. Once you've done that, the eye will then be filled with a 2% sodium hyaluronate solution, which is very optically clear. Here we go with that now. It's important to backfill and overfill the eye so that it's overpressurized, and you want to see some of the viscoelastic coming out as it has here. Next, the desired size of the capsulotomy is set on the console. The surgeon then places the foot onto the foot switch and we're ready to go. What's interesting is that you can detect intumescent cataracts because within the focus guide, the absence of reflection lines from the natural crystalline lens indicates an intumescent cataract. If you compare what you see on the right, where the two lines, the diagonal lines come together, which give you your focus point, with that on the left, you'll see that there's no line reflection seen on the left in the intumescent cataract. So you turn on the laser, you center it, and then fire. So here we can see the laser beam. As we heard before, the reflection lines are not seen there, but you can see the focus point. It's now centered. And once you've got it centered, you then fire. And in 0.3 of a second, you have a perfect centered round capsulotomy. And note how the liquefied cortex is held back by the anterior chamber being pressurized by the high molecular weight OVD. And you see it doesn't come forward at all until you start to disturb that surface by taking the capsulotomy cap away. The lens is now in place and is centered very nicely on the capsulotomy as we would want it to be, with 360-degree coverage. So in summary, selective laser capsulotomy with capsule laser provides a new approach for the intumescent cataract. Microfiltered trypan blue is used to identify the anterior capsule and its landmarks. A pressurized anterior chamber with high molecular weight OVD is used to avoid the Argentinian flag sign. And the laser capsulotomy with a consistent size, circularity, and a strong elastic edge is created in less than 0.3 seconds. There's easy identification of the capsular edge during nuclear removal and lens implantation, and 360-degree IOL coverage due to a well-centered capsulotomy assists in PCO prevention. Thank you very much for your attention.
Thank you, sir. What a lovely presentation. I see from the presentation that the capsular edge is stronger more resistant to tear because the collagen type 4 changes, amorphous collagen, and the edges are rolled out.
That's correct, yes.
Right. Somehow we understand that the same concept works for micropulse technology too. The change of collagen, amorphous collagen, and the edges rolled out, and that gives it more strength and elasticity.
Correct.
So is there a comparison between these two technologies?
In terms of the edge strength, no.
Okay. The second question would be, sir, that even though it's a very fast maneuver and it makes a rhexis, what at that particular moment the patient squeezes and the eye rolls up or something, would the laser stop or would it continue to fire?
Well, currently we are actually fixating the eye by using something like a Thornton ring, so that the amount of movement the patient can make is minimal, and it's quicker than a saccade. You know, there've been, as I said, there've been over 4,000 eyes done. Now, admittedly, until recently, they were using a patient interface that was holding the eye, but there have been no instances where the patient has been able to move sufficiently fast to cause the capsulotomy to become not round.
I have a question for Mr. Richards. Yes, the size of the rhexis, it changes, or it's one size for all patients?
No, you've got a variation. That's why the console was there to set between 4.5 and 5.5. And we're looking to expand it possibly down to 4 and up to 6.
And there is any changes, negative dysptopsia, because their edges now is become rolled up outside. So is this going to decrease the negative dysptopsia for the patient or not?
No, there's been no instance of any issues in that regard, no.
Okay.
We have a question from an attendee, Dr. Jagdish. He has asked about what is the potential cost of this laser and is it available commercially?
It is now available commercially in certain markets. It has been rolled out to a number of places in Europe. It is now available in Australia, and it will be available in India shortly, within a year. As to the cost, to some extent, that depends on the deal that you do. I mean, one of the things that is interesting is that since we have found that we can do without the patient interface, this cuts the cost of per case very considerably.
If you compare it,
by the time you get the OVD and the dye and some HPMC and the that's it. The cost is very low indeed per case, significantly lower than precision pulse capsulotomy.
If you were to compare it with, say, for instance, Zeptro, then what would be the cost? I mean, in UK, Zeptro is there, is not there?
So it will be significantly less than half.
Less than half, okay.
So I think that was really enlightening hearing all the 5 talks. I must congratulate Namrata and the scientific committee for having been able to get all of you on this platform, and I'm sure all the attendees have really benefited. I must say I have by the talks as well as the interaction. So I would like to thank everybody for having participated.
Thank you very much indeed.
Thank you, everybody. It was a lovely session, very interactive.
This only tells us that we need to have a dedicated session on bilateral simultaneous cataract surgery.
I'll be there.
Session is required.
Yes, okay, thank you.
We have already people who will be participating in it in the next webinar or next platform. Thank you.
Thank you, everybody.